Thank you, Mr. Cookling, Rainer, ebiga-VISION, Max, for all your visionary work and your multiple awards. I see you continue to overachieve. But today, I'm very pleased to represent nutritional biochemistry of the eye. And I'm very fortunate to represent that at the beginning of this talk, because what we want to do is keep the vitreous doing its job for as long as we can. And we're going to learn about lots of new pharmaceutical options and new ways to image the vitreous and biochemistry of the vitreous and so on. But I'm very interested in patients that suffer with vitreous floaters. And in fact, as Dr. Jerry Sibak says, we shouldn't call it vitreous floaters. We should call it a disease name, vision-degrading myodesopsia, because it sounds scary. That's what he said, at least. But we do know for these patients that they do really suffer. And therefore, the question is there something we can do with the vitreous? So we must, as he says, look at the vitreous and not just through the vitreous. Robert has already introduced me, thankfully, but he is correct to say that our work has focused on the study of human nutrition for visual function, which has led into brain function. And the interconnection between the eye and the brain is truly remarkable, including what we've learned about how targeting nutrition at the macula can do for diseases like macular degeneration. But this needs to be proactive and not reactive. And my big hope for ophthalmology is that we can be much more proactive with targeting nutrients. It's not just about good food or good nutrients, it's about knowing what the nutrients are in good food, identifying those and making them bioavailable to target tissues, including now the vitreous and what we've learned. So we must not just look through the eye into the back of the eye. We have this wonderful structure. 80% of the eye, as you know, is the vitreous. This is Jerry Sibak's image, and as I said, it is invisible by design. We only care about the vitreous when we start to have problems. We have the conversation. So the question is, how long can we keep it invisible by design? And our scientific experts today will speak about the various biochemistry elements of the vitreous, but put simply, it's a more liquefied version of the cornea. We have dominated by water, of course, and we have our protein, hyaluronan molecules, etc. And we also know that this structure, which is protected and scaffolded by the collagen protein, is also stored with an abundance of nutrients. And our job was to identify what are those nutrients. We should remind ourselves within eye care, and we can look at the many kind of definitions and functions, if you like, of the vitreous body and what that allows us to achieve in terms of our visual functions. But it allows the eyeball to exist, and it provides the optical environment by which your patients receive light, and that light is transmitted, as you know, to our retina, where we have this beautiful sensation that is vision. And everything is okay until it's not okay. And everything is okay until light can no longer move through that optical system. One of the most important discoveries that I believe we've had is the new knowledge around the fact that the vitreous is not a totally closed system. We discussed last night at dinner about we're born with the vitreous, it exists, and it never changes. And this is what I really question and would like to continue to question in our own scientific works. But particularly around nutrition, I think there is now agreement that there is a turnover of the antioxidant nutrients, the antiglycative nutrients that exist and are working within our vitreous. And that's crucial, because that means we can make a change that makes a difference. The question is, what should we change? When should we change? And what is the effectiveness of a nutritional change of the vitreous, which we can now achieve with VitroCap supplementation. Also, we know that in this proactive world, we should understand the severity of which vision-degrading myodesopsia affects patients. And it's not as simple as advanced degeneration equals the the worst type of suffering. We actually can see suffering in patients that is long-standing from a very early age and with even very early changes in the vitreous. And we have been able to monitor and map those type of visual-related quality of life changes in sufferers with vitreous floaters. In our experiments, we obviously work with patients who choose to or who are not suitable to have vitrectomies. We'll learn about vitrectomy a little more today. So then the question is, what is this change with nutrition? Reminding ourselves of the impact, as Sibak, this is a very nice commentary piece by Dr. Sibak, which shows that patients with this disease, vision-degrading myodesopsia, suffer as much as patients with macular degeneration. And they suffer more than patients with disease like glaucoma, etc., diabetic retinopathy. So it is a real disease and it is a real problem for vision. And Sibak et al. Have been able to quantify that in terms of what this means for the patient. Our own literature review nicely, so this is work from a PhD student in our laboratory, nicely summarizes the amount of nutrients that we've identified that are now present. Notwithstanding, we still have challenges to measure these in the vitreous. I was speaking to Max briefly about this last night. But we do know that there is an upregulation of certain combined micronutrients, including what you see here, ascorbic acid, vitamin C, zinc, and we see lots of other co-micronutrients. And in biochemistry, we know that having the harmony and the balance of these micronutrients is crucial to these nutrients to be able to deliver their antioxidant effects or their enzymatic effects or their antiglycative effects, which we hypothesize that they do when they are working within our vitreous. So using the VitroCap supplement intervention, we had a pre-published protocol which allowed us to conduct a double-blind, placebo-controlled clinical trial called the FLIES study. Here you can see a summary of the bioactive micronutrients and their proposed mechanisms of action that they would be able to exert within a healthy and optimized vitreous in terms of nutrition. It was a 6-month intervention period. It was a 50-50 double blind. So these patients were not suitable or elected to not have vitrectomies, but they had long-standing suffering. Here you can see the exact concentrations of the micronutrients that are present in VitroCap. One major important piece, and I've seen Dr. Sibak speak about this, is how we qualify the patient's suffering. And the standard validated vision-related questionnaires up to now have not been suitable to quantify how a patient feels about their suffering and how we can report on same. So we worked with our statisticians to develop a customized disturbance questionnaire, which essentially assessed the suffering in their daily life, but over a period of time, say 6 months previous. And there was a mathematical mechanism by which we were able to quantify that thereafter following assessment. Here you can see the type of questions. The results now to show you in my last 3 minutes are as follows. The blue line presents the placebo response, which with something like this we certainly see. A patient that is given an intervention will convince themselves at some level the intervention is having benefit. And we picked this up ever so subtly in our 6-month intervention. However, when we looked at the multiple of tests across vision-related quality of life, we can see a real-time treatment effect, which means that over time, these patients noticed a positive change, and that positive change was significantly greater for those on the VitroCap active intervention compared to placebo. We also wanted to quantify, and I believe we will have a presentation tomorrow in another symposium on new techniques on quantifying the vitreous. This was crucial for us to do as well. So we used a Heidelberg Spectralis system, which was optimized with wide-angle lens, movies which were repeated on triplicate times to check variability, which scored really, really well. So we were able to put some level of quantification on the vitreous. Here we can see an example in the active group of a vitreous changing over the 6 months. We look at the baseline, we can see a measure of 368 centimeters squared. Following intervention in this same active group, we see a significant reduction, almost 2/3 reduction in the physical issues of those conglomerates, those vitreous floaters that are present. This is an exaggerated event from one patient, so for demonstration purposes, I wanted to show that. However, looking at the placebo, we see a very same, as you'd expect, starting point, 394 centimeters squared. But interestingly, you see, not only does that not get better, it actually gets worse in these patients, and we see this trend. So the concept that vitreous floaters will disappear, the problem will go away, I think is something that eye care needs to be very alerted to. These patients continue to suffer, and in fact, the data shows us that their suffering gets worse. So on average, we see about a 70% decrease in floater area in a significant number of patients on the active compared to placebo. In my last 24 seconds, I will show you the overall correlates of the results, which are consistent with each other. Today, I didn't have time to show you visual function, which is crucially important when assessing patients with vitreous floaters. And they lose their contrast sensitivity highly significantly. And we were able to see an improvement in contrast sensitivity following 6 months intervention. And those improvements in vision were correlated with their subjective, how they felt about their vision, but also mirrored perfectly well with our imaging assessment. We did have about 30% of patients in this experiment that didn't respond, and this will require further research in terms of dosaging, using more, and maybe even optimizing further the formulation that has been created for this intervention. I will say that this is one gold standard study, but it is only the sum of the parts. And what I mean by that, we're now approaching nearly 1,000 patients that have been assessed and have used this successfully in clinic setting and clinic studies where doctors and patients alike are reporting back same results as what we demonstrated in the FLIES study. So here you can see the conclusion, and the clinical relevance of this is major indeed. As I said at the outset, nutrition is the starting point of maintenance. It is my personal view across all sicknesses, if we can reduce oxidative stress of a tissue such as the vitreous, we can go a long way in stopping what happens upstream with degenerations, inflammatory responses, etc. And we now know what those nutrients are. You now have the option as clinicians to be proactive with a nutritional intervention that is evidence-based and has been tested now for over a decade. And I congratulate Mr. Cookling and Reiner on their work with ebiga-VISION and VitroCap. All of our publications, and there's now many, are available on my own website, and maybe I'll have time to answer some questions, if not now, but throughout the day I'll be available and look forward to discussions. Thank you, Max. Thank you, Robert. I think Max said we have time for questions.
I think we have time for one question. Anyone from the audience? Otherwise, I would like to ask a question. Do you have any ideas how you would improve the formulation? If you could restart now, would you change it?
Yeah, the answer to that will be delivered when you do more work showing us how to quantify it. And then we can see, because that's important, you know, how much of it is getting in. And that's the missing piece, I feel, Max.
Does it penetrate the blood-retina barrier?
Yes.
And could you measure it? So if I would do a vitrectomy in a patient who had taken it and a group where wouldn't have it taken?
Yeah, a great question, yeah. So, and again, Max and I spoke briefly about this. The current techniques, we're using HPLC, mass spectroscopy, the sensitivities of those and the methodologies around those We can measure specifics. We can do vitamin C, we can do zinc. So when we have any tissue, we can measure that. But the levels are very difficult to kind of separate and quantify, but it is a missing piece.
Thank you so much, John.